السلام عليكم ورحمة الله وبركاته. طبعا يعني this is not true. Presidents always stand here and other friends do the job. That's it. صباح الخير. I'm going to talk to you about a case about pelvic fracture in young children. Should we fix? And I think we have to define what's young children. Could you tell me what is the young children are? Anyway, they usually classify young children as the preschoolers from 3 to 5 years. They are too young for fixation, I think, for pelvic fractures. I'd like to start with this case of not young child, 9 years, motor car accident, and this is his X-ray. Would you choose any treatment for him? دكتور وائل معنا يعني he's an outstanding pelvic surgeon. He may help us in decisions making in these cases, or Professor Ahmed Dasuqi. CT, that's right. This is an excellent job. CT has to be done. But let's complete our series of plain X-ray. And unfortunately, the surgeon didn't do the CT for this patient. So that's all what we have. This is should be outlet, and this should be inlet, and this should be AB views. According to what is available, could you suggest any treatment for him? He's 9 years old, motor car accident, male, and that's it. As I can see, there is a catheter. I think he was associated with urethral injury at that time. This is a history of the patient, actually. This is the initial treatment, and this is the X-rays that was with the patient at that time, and he's treated in Cairo, by the way. Anyway, the conservative or surgical? Conservative? Dr. Ahmed?
It looks
Surgical?
like, according to the available X-rays, looks like type C. I think it needs surgery. It needs at least posterior segment fixation, iliac screw maybe.
Well, do you agree? Okay, actually we have to ask CT, as Professor Hassan said, but unfortunately the surgeon didn't do. He treated conservatively, 5-month follow-up. That's when I see the patient, and you can see, of course, the migration and the malunion at the sacroiliac joint at the arrow pointed. This is a follow-up X-ray. The lines is disturbed really, and clinically the patient has shortening, as you see. The first message of this, we have to do the CT. We have to thoroughly evaluate the patient, and we didn't have to hesitate too much in surgical decision in such patient. Actually, the standard treatment in children for pelvic fractures was conservative treatment, depending on the higher ability of those children to remodel. However, this concept is changing now. This is another case. This is a young child, 3 years old, and he has sustained this injury. This is the AB view. He is associated fracture shaft of the femur, comminuted of the proximal third, and this is inlet view, and this is the outlet view. And this is the CT, because I'm ready now by the CT. As you see, the sacroiliac joint is really open. And this is the CT also. The red arrows point to the fracture, and this is the reconstruction CT. Now, opinion. He's a young child, 3 years old. Conservative, surgical. Conservative? No? Surgical? All people surgical. He is young, 3 years old. Okay, that's a nice decision. But what is the mean of fixation? Anterior, posterior, anterior, posterior. Anterior, posterior. Anterior, posterior. External fixator, anterior. No posterior.
I evaluate after exam fixator the posterior element. I see it.
دكتور محمود. percutaneous iliosacral screw. You want this one? This one? First cut, second cut, reconstruction. Which one? First, second, reconstruction. Anterior and posterior. Dr. Ahmed, you have an opinion. Anterior and posterior. Okay. He is 3 years old. Are you safe to put an iliosacral screw in a 3 years old child? You are brave enough. I'm not. Yes, anterior. That's what we did. Actually, the patient was reducible in the C-arm, and we did the supraacetabular external fixator, anterior, and we put one elastic nail in the fracture of the shaft of the femur. This is the post X-ray, and this is the follow-up X-ray, 6 months.
حبيت اعمل ريجيد فيكس، انا وجهه نظري يعني ان انا هعمل له انتيرو اكس فيكس وهقلبه برون وهفتح فتحه صغيره بالسيرور وادي له مسمار، او ممكن يبقى بيركوتينيوس كاللاترال كومبريشن سكرو وما اخدش الساكروياك سكرو، على الرغم ان احنا بناخد برضه الساكروياك سكرو في 3 سنين وفي 4 سنين، وساعات بستخدم الريكونستراكشن بليت الصغيره مكان الوشر، عشان ساعات في الوشر بيغطس مننا في الالياك بون عشان بتبقى طريه يعني انا ان فيفر مع ان اعمل كومبليت فيكسيشن رازر ان انا اعمل، لان الانتيريور فيكسيشن هيديني بارشال ستابيليتي، وده طفل صغير. هو طفل ممكن حضرتك لو سبته بيد ريست كده هيلحم في مكانه، لو هو باد لك هيحصل له ديسبليسمنت. فهي الفكره الفيكسيشن انك بتبقى سكيور من الكلام ده، فلو انا دخلته عمليات هعمله بالمره توتال فيكسيشن كومبليت فيكسيشن، فبالتالي ادي له كومبليت ستابيليتي.
I have a question for you. What is the youngest child did you fix? How many years?
3 years. 3 years or 4 years.
Did you fix a 3 years old child? In fact, in literature, I searched for, to my knowledge, and I didn't find 3 or even 4 years a child with fixation. And the concept, the standard concept is still conservative treatment. That's why I really arouse this question. The standard concept in the literature is conservative treatment. However, with associated malunion and the long-term sequelae of those fractures, we actually started to think about operative treatment on those young children, and I think we have to do the minimal operative for those patients. In my concept, anterior fixation is enough for this patient. Maybe the posterior element here is not reduced perfectly, but in a way you will see the follow-up. I respect your point of view, of course. That's why these cases, I said in the beginning of this conference, الحقيقة أوجه، يعني مش لازم الإجراء اللي أنا عملته أو اللي عمله whoever the surgeon يعني يبقى هو ده الإجراء الوحيد والصحيح، و that's why we are here يعني. دكتور حسن تفضل حضرتك.
هو ده اللي بيحصل، يعني مشكلة قوية جدا حضرتك، كمية الحالات اللي بتتثبت ومش محتاجة يعني احنا معظم الأطفال are over treated مش under treated، لأن معظم الأطفال بيروحوا الأدلت سيرجنز. تمام؟ يعني أنا موافق تماما إن احنا هنا السوفت تيشو is more than enough مع minimally invasive in anterior fixation. ده كده حل رائع جدا. تمام؟ وان نانسي نيل ما هوش حاجه موجوده في الليترشر، بس انت حاطط نانسي نيل في واد عنده 3 سنين يا بيه كويس، ما فيش حاجه اسمها نانسي نيل واحد، بس الواد عنده 3 سنين، احنا حاطين حاجه فيري مينيمال وبسرعه عشان الولد ده من الواضح ان هو بولي تروما. يعني هو اكيد كان عنده حاجات ثانيه كتيره، انت هدفك تستابلايز قد ما تقدر وتباس اول مثلا اللي هو بيقولوا الجولدن اور لايف سبورت والفيرست 3 دايز والكلام ده، وما تبقى هو الولد لوحده 3 سنين هيعدي بسرعه قوي. تمام؟ احنا لما بنفيكس ادلت انتيريور بوستيريور لان احنا محتاجين فيكسيشن ذات لاست لغايه ما يحصل يونيون، انما انت في واد عنده 3 سنين البوستيريور اليمنتس هتلحم في اقل من اسبوعين، والانتيريور اليمنت انت كل اللي عملته يو ادد شويه ستابيليتي عشان ما يحصلش بوستيريور مايجريشن زي ما في اول حلقه حضرتك اول ما حطيتها قلت لك سي تي، لان اتس فيري كومن لما يبقى ولد عنده 9 سنين ما عندوش سوفت تيشو كويس زي الصغير ان هو يمايجريت، وبتبقى الاوبشن اللي قدامنا لما يجي لنا بالمنظر اللي حضرتك عرضته ان يجوا بقى بتوع البلفس يكسروا تاني وينزلوه ويعملوا فيكسيشن ونبقى عارفين ان في محضرين دم كتير. لان البوستيريور اوستيوتومي از فيري بلاتي. يعني احنا عندنا كذا طفل جولنا ببروكسيمال مايجريشن وشورتنج 3 سم و2 سم، ما عندناش اوبشن غير ان احنا يا نعمل اوستيوتومي يا نلنثن الليمب. تلنثن الليمب حاجه الولد ما بيشتكيش غير من الليمب لينث انيكواليتي، تمام؟ وتبقى هو الاوبشن اللي قدامنا. انا كان نفسي يبقى الديسكشن طب هتعملوا ايه للولد ده؟ هو عنده شورتنج والشورتنج ده مش هيتصلح الا بعمليه. هل نطول الفيمر which is a very rapid solution وسيف وجميل، ولا ان احنا نجيب pelvic surgeon يعمل لنا اوستيوتومي ويفكس؟ احنا لما عملنا كده الدنيا اتصلحت، بس العمليه تقيله قوي بجد، ويعني هم نفسهم كانوا خايفين. بس انا يعني احيي حضرتك جدا ان حضرتك حطيت one Nancy nail which is يعني it looks very odd بس it's very wise، وان حضرتك حطيت external fixation. لو احنا بنتكلم على رينج فراكتشر لازم افيكس ورا وقدام، بس عشان انا طفل عندي 3 سنين لا، احنا مش محتاجين نعمل ورا وقدام.
Thanks, Professor Dr. Hassan, for enrichment of the discussion. Yes, the standard indication for elastic nails, I think above 4 years old. But how can I treat this? I can't do hip spica for this patient. That's why we put only one nail. Thanks for support. And this is a follow-up X-ray. This is a 12-month follow-up X-ray. This is a 1-year follow-up X-ray. This is a patient almost dancing, and I don't know why they test the range of motion, but anyway, that's the photos available for the patient. To the take-home message, non-surgical management has been the standard of care due to the remodel power of the children. CT is mandatory, as Professor Hassan highlighted this. The decision to surgically treat this fracture depends on the nature of the fracture, the dislocation, the displacement, and associated injuries. Anterior fixation may be enough for young children. That's an opinion. That's the 3-year-old patient after fixation, 1 year post-operative. I think he's doing well with anterior fixation only. Thank you so much.